is Nicholas Cassimatis, and I will be presenting comparison of interlaminar and interspinous stabilization devices to fusion and decompression for the treatment of back pain in the context of lumbar spinal stenosis and low-grade spondylolisthesis. This is a review of literature. The authors have no conflicts of interest or disclosures to report. So for our introduction, a little bit of background. The interlaminar stabilization devices, ILSD, and interspinous stabilization devices, ISSDs, have been used as an adjunct treatment for decompression in lumbar spinal stenosis for some time. Treatment modalities for lumbar spinal stenosis and back pain in lumbar spinal stenosis specifically often start with non-surgical conservative treatment and may eventually include surgical decompression with or without fusion, depending on the nuances of the case. The main criticism of decompressive laminectomies for back pain is that the improvement in back pain is difficult to predict. And in addition, the potential spinal instability remains unaddressed or possibly worsened as a result of a decompression. So if there is some degree of instability, decompression can really not provide an optimal outcome. Posterolateral fusion with pedicle screw fixation that eliminates motion and may contribute to pain control and may prevent recurrence of stenosis, but it's at the expense of a more invasive operation. However, this intervention is associated with development of undesirable sequelae, including adjacent segment disease, loss of range of motion, and pseudoarthrosis. So fusion is not necessarily a benign option either. ILSDs and ISSDs hope to provide a relatively less invasive approach that will maintain stabilization while preserving motion and foraminal height. So to expand on the interlaminar stabilization device, ILSD really refers to a device called the Coflex, which was an FDA-approved implant that came to market in 2012 that increased interlaminar stabilization following decompression. It's for use in patients with a 1 or 2 level lumbar spinal stenosis and up to a grade 1 spondylolisthesis with minimal dynamic instability, meaning the vertebrae do not move relative to each other. And when I say that, I mean the vertebral bodies do not shift pathologically on each other. The Coflex device is ideally positioned deep within the interlaminar space of adjacent spinous processes sitting on the lamina to provide neutral stabilization and preserve spinal kinematics. It allows for compression while in extension while permitting normal flexion. You can see the Coflex device on the right side of the screen. And it's made of titanium and has this sort of U shape, and again sits in the interlaminar space between the processes. Our objective with this investigation is to determine if any difference exists between the different procedures in regards to long-term back pain outcomes. For our methods, we undertook a systematic review of literature, articles comparing the use of ILSDs, interlaminar stabilization devices, and ISSDs, interspinous stabilization devices, to fusion and/or decompression using the PRISMA checklist. The search strategy included the following terms and their associated medical subheading terms: interlaminar support, interlaminar stabilization, decompression, and fusion. Outcomes of interest included operative time, back pain measures, and reoperation rates. Databases were queried for studies comparing the use of interlaminar stabilization devices to decompression and/or fusion between 2012 and 2022 with a follow-up of at least 24 months. Data was collated from the papers and analyzed using an SPSS method. So something I just want to clarify before we move on, we included interspinous stabilization devices as well in this investigation, more for a historical perspective. They don't really get used anymore, but just to observe how the field has progressed. And even the Coflex, which is really our interlaminar stabilization device, used to be branded as an interspinous stabilization device before it became better known that it was actually using interlaminar support due to the depth of the implant and where it really was situated. And the Coflex device is almost always done with a decompression. So we'll clarify that point a little bit later, as only one of the papers included looked at it as a standalone, meaning without decompression. For the results, our search identified 707 papers. After exclusion and inclusion criteria, we ended up with 9 papers to be included in our literature review. Of the 9 included studies, 5 studies were randomized control trials and 4 studies were prospective cohort studies. We identified 406 patients who underwent ILSD, the interlaminar, and 123 who underwent interspinous, 351 who underwent decompression, and 195 who underwent fusion. Across all studies, interlaminar and interspinous device groups experienced lower operative times and lower blood loss compared to fusion and or decompression. All interventions yielded similar improvements of back pain. Interlaminar patients were less likely to undergo reoperation than interspinous patients. It's part of the reason that interspinous devices fell out of favor. And the interlaminar group was far more likely to undergo reoperation compared to decompression, although that measurement is a little muddied for reasons I will get into later. The likelihood of reoperation was fairly similar between the interlaminar groups and the fusion groups, however. So here we have our operative times broken down by each paper. And again, these are largely in minutes, and we have statistical significance if it was reported, and which interventions were really being compared through this process. But as you can see, the interlaminar and interspinous devices were across the board less time. And that makes sense. You're just doing less in terms of operating. So it's a shorter procedure. For the back pain measures, the vast majority of the studies used the VAS scaling system. One used the NRS-11 and another used the QB-PDS. And again, we can see all the way on the right, the interventions that are being compared, the studies all the way on the column on the left, and then the different outcomes that we're looking at, as well as, comparing the ILSD or ISSD to the control, which is either decompression or fusion alone. Something worth mentioning, the Baer et al. Study was the only one that really looked at the ILSD or ISSDs as a standalone, meaning without decompression. And but if we look at all of our results here, right, we're seeing that all the scoring systems view the results as fairly comparable between different modalities. For the rates of reoperation, they're pretty similar in many capacities, but we do see that for the Baer et al. Again, which just used a standalone method, the ILSDs, or excuse me, the ISSDs had significantly higher reoperation rates than the decompressive groups. But again, the vast majority of the other studies were looking at decompression as standalone, with the Coflex also including a decompression, or the ISSDs also including a decompression implied with the procedure. Some of the others still do show that decompression has a slightly lower rate of reoperation, so that's something to note. But amongst ILSDs and fusion, we're seeing pretty comparable results, and many studies between ILSDs and decompression, so long as the ILSD included decompression, found very similar reoperation rates. which I don't think is particularly surprising given both modalities had decompression implied. So what are our real takeaways with this? And I think the main thing is that the interlaminar stabilization devices, such as Coflex, offer a less invasive alternative for patients with back pain or mild instability in spinal stenosis, and they come with relatively little operative time and blood loss. It may not be as satisfactory in some cases, but I think it may be a good first step for patients that are not great candidates for a more invasive procedure. And it still preserves the option to do more invasive procedures after the device can be removed. But again, a relatively simple spine operation for patients with back pain or mild instability in lumbar spinal stenosis. Something that is notable that goes against the use of ILSDs is the reoperation rates. ILSDs do have a slightly higher reoperation rate, but there is a staggeringly high reoperation rate for ISSDs, which again, the interspinous don't really get used anymore, but we still ought to look into why there are higher reoperation rates within the interlaminar cohort. Again, not dramatically higher, but still slightly higher than the controls of decompression and or fusion. One of the reasons that some suspect this can be the case is that because the interlaminar device may be used as a less invasive option, potentially as a first step before considering something like a fusion, maybe some of the patients are not perfectly selected in that maybe they ought to benefit from a more invasive procedure, but preferred a more conservative operation. Just something to consider. There's no great data out there on something like that, but it has been speculated. So there's really similar efficacy in the treatment of back pain amongst all of the groups. But it's important to note that the identification of the specific back pain generator in a given patient is really critical in deciding the appropriate intervention. There are different reasons to use each of these devices, especially in different populations, or instead of different devices, I should say, different procedures. Some patients may be more amenable to more aggressive procedures or less aggressive procedures, depending on their physical situation. But at the end of the day, it seems that the interlaminar stabilization devices, such as Coflex, seem to offer some ability in treating back pain in patients with lumbar spinal stenosis in carefully selected patient populations, right? And that's really the key takeaway, is that this can be a good option for a carefully selected patient. And that brings us to the end of our presentation. Thank you again for hosting us. And if you have any questions, feel free to reach out at the email listed here. I'm happy to be in touch. But again, thank you for hosting. I was happy to be here. I really appreciate it. And hope you all have a wonderful day.